So today I'm interviewing Karen Kirkham, Integrated Care System Lead in Dorset. Dorset has made incredible progress coordinating the work of PCNs and the local voluntary sector. And Karen today will be telling us more about their population management program and what it has been able to achieve during the pandemic. Hi, Karen.
Hi, thank you for having me.
Would you like to start by telling us a bit more about your role, first of all?
Of course. Well, I'm still a practicing GP within the NHS, a partner in a practice that I've been a partner in for around 25 years. I also, in the last 10 years, have worked within the Dorset system primarily as now the integrated care system clinical lead for the Dorset system. So my role is less about being a CCG commissioning GP and much more about how I can help to promote integrated care as a principal for the Dorset system. So I spend 2 days a week in Dorset, and then I spend 2 days a week with the national team, the NHSEI team, as a clinical advisor in systems development and population health management. So I have the privilege of having a role that spans from policy to implementation of the policy and strategy to working at the front line on a weekly basis.
Great, great. And before you tell us about the population health management program in Dorset, it would be good to hear what population health management is.
Yeah, sure, of course. So population health and population health management are two slightly different things. Population health is an approach which is aimed at improving the health of an entire population. It's about improving physical and mental health outcomes and the well-being of people, whilst reducing health inequalities across a defined population. And it includes an action to reduce the occurrence of ill health, including addressing the wider determinants of health, such as housing and the choices that we make as a population. And it requires working with communities and partner agencies. That's a very strategic view about population health. Population health management involves improving population health by using a data-driven planning and delivery approach. So it's a very proactive approach, looking at how we segment local populations, risk stratify them, think about how we can identify local at-risk cohorts, and in turn design and target interventions which are aimed to both at prevention of ill health and improving care and support of people in a more holistic way, in a more integrated way. And again, really trying to reduce those variations in the health outcomes that can exist. And there are 5 overall aims of population health management as a result of that. Of course, first, to enhance a patient's experience of care. Of course, to improve the health and well-being of the population, but also to address these health and care inequalities that exist. And then in addition, and really importantly, to try and improve and increase the well-being engagement of the workforce, the people who work within our local populations in a better and more meaningful way, and all at the same time looking at how we can spend our money wisely, and so we improve productivity potentially, but also reduce the per capita cost of healthcare. So we're moving away from really expensive interventions and moving more downstream into rising risk and understanding how we can, at a person-centered level, improve care. So that's what population health is in a nutshell.
Great, thanks, Karen. And how has the population health management program been working in Dorset? What impact has it had on service delivery and on local residents?
Sure. So Dorset was undertook the first wave of a big national programme at trying to embed population health management as part of our integrated system. And to that end, we were one of the first wave systems, and we started just a little over 2 years ago, looking at the approach of exactly how I've described, trying to look at local populations and trying to think about what we did differently with them. And so I have to say that it was a 20-week programme that we undertook in partnership with the national team and development partner Optum. And that programme allowed us to look at very local populations, looking at our own linked data set, to allow us to look at certain populations and think what we might do differently about those populations. And it's been a whole journey of experience for us, because for the first time we developed our own linked data sets, which actually we have grown a data set that now includes data from every general practice. Every 24 hours comes into a Dorset held data warehouse that links that data with secondary care, community services, mental health. We've got some local authority data now coming online, which allows us to look at deprivation within our population for the first time. And so this amazing and immense infrastructure that we've been able to build allows us then to create the insights. So the insights are where the magic happens, where we come together with analysts, with clinicians, with managers. We look at our population and we try to work out what we could do differently from those populations. And so we initially rolled that across 4 primary care networks who were willing to take the challenge. And they produced insights on everything from care of people with respiratory disease and COPD to using the data to help identify improving outcomes for people with diabetes and mental health issues. And we used it as an approach, a quality improvement cycle approach really, and a building of new multidisciplinary teams to address health problems in a different way. So for the first time, we started to build new teams, regardless of the commissioner, the lead provider. We started to bring people together around cohorts of people that we thought we could make a difference with. And then we've rolled the programme now in successive waves in Dorset, and the programme has been very successful in England and is now aiming to be rolled across every integrated care system in England. So it's an exciting opportunity for everyone to come on board and learn some of the skills. It's a peer-to-peer learning action set type approach. And then fundamentally it's docked in with some of the other key policy areas around primary care network development and now place development as part of our integrated care systems, so that we can develop the tools to be able to deliver care differently. So a couple of examples around that where we used the data to look at people with COPD, chronic obstructive pulmonary disease, who were being frequently admitted to hospital. And we developed a risk stratified approach to their care, so that people who were very poorly and that people at the kind of the highest risk, we wrapped multidisciplinary teams around them, including physiotherapists, including mental health workers, including GPs, of course, and of course the respiratory consultants. But also then, as we explored through those people that we were looking after, there were things like housing was an issue, and access to heating was an issue, and therefore it was having, and there were damp in the environment. And so we started to have a much broader holistic approach to the new partners that we needed to work with in the local system. It's just one example, and there are very, very many more, but it is really a way of working that allows us to look at the data drives, the insights that drives the decision making at a local level, brings forward new teams, and we have to have a really clear view on the outcomes that we're wanting to achieve in a slightly different way. So it's a holistic program, and but one that I think is going to be a very core and central plank of work for all systems going forward.
That's very interesting. And as you mentioned, primary care networks and their multidisciplinary teams have worked much more closely with the VCSE to develop holistic interventions. What has made that possible? So could you tell me more about how this shift has taken place? Are there any structures that have been introduced to systematize that collaboration with the VCSE? And how have VCSE organizations been mobilized?
Okay, great questions. So I think very much through the last year in COVID, I think we've seen a big acceleration in the way that we work with the voluntary care sector. And I'll give some examples of that, but I think just to bring us back to and just slightly to set the scene around primary care networks. So in all of our local systems, a little over a year ago, really, primary care networks were launched. The primary care networks, at their most basic, are a bunch of GP practices working across a geographical area, 30 to 50,000. We know that that sets the right kind of size for a population and team-based working. And additional investment has gone into those primary care networks to grow a number of additional roles. So roles that weren't always in the traditional general practice sphere. So we start to think about multidisciplinary approaches. Those roles did include physiotherapists, pharmacists, paramedics, and now increasingly we're using some of that funding to identify non-medical roles, because of course we know that so much of need within a local population is not just always related to health, but it's also related to needs that are non-medical needs. So we were able to use some of the funding to support those primary care networks development to identify things like social prescribing link workers and care coordinators, health coaches, and so on and so forth. So suddenly we have a policy platform that allows us to connect an increased and more diverse workforce within our local primary care networks that we can then use in a different way to support communities. And now I come to COVID a year ago, so a little over a year ago when the first lockdown happened, we started to think about how we could use a population health management approach, so use the data to identify vulnerable patients living at home, shielded patients, and then thinking about how we could use those social prescribing link workers to identify specific cohorts of patients or even specific patients, and think about how we might use our voluntary sector partners in those local areas to help support patients differently with all that was going on with COVID. And so we started to use that approach, and we found a number of people who were helped in a completely non-traditional way that we wouldn't normally have as a GP, being able to think about how we might help. So we worked with a community interest company who helped us to create a really amazing directory of services across our Dorset area that was obviously very relevant to each local network neighbourhood area. And they help us to identify where we can go to help in a really consistent way. We use the social prescribing link workers to link with the patients to understand their needs, and then link back with the community interest company, Help and Kindness, who help us to identify the local services that are there. And that then allowed us to have a range of interventions, some of which were as simple as allowing an iPad to be given to someone who was so socially isolated that they hadn't seen any relatives in months and months and months, but allowed that human connection that would never have happened if we hadn't been able to access just some simple technology that they absolutely couldn't afford to put into their homes. It allowed us to connect with people around shopping and picking up prescriptions, and allowing them to be maintained at home in conjunction with the local authorities around us and social care around us, but took the pressure away from core services by that amazing voluntary community sector offer that came together around local communities to help themselves, to help their practices and help their local populations. So it really has been an astonishing year of change and embracing a community sector provider in local areas, because that's what community development and using community assets is all about.
And I imagine that a key part of this process is mapping your landscape, understanding which community assets you have available, which community organizations are operating out there to support primary care networks. And I understand some of this work has been taking place in Dorset. Is that correct?
Yes, that's right. So for a little while now, we've been talking as an integrated care system about how we can engage more with community and voluntary sector partners. That for certain has been part of our integrated agenda, which starts to look at the whole of the community assets. I've given you some very specific examples, but actually we recognise the need to embrace the voluntary sector and ensure that it has a route into our local services and is valued by our local services. And that's so I think there are different levels of engagement within the community and voluntary sector. So there is definitely a leadership role for our key leaders within the VCSE to take their part within our local system and help us understand what those assets are. There is also something that is very important within local neighbourhoods to understand what their assets are, and that's where, you know, working with them to understand a consistent offer around the services that are available to local people is really important. One of the problems that we've struggled with over the years in terms of health is charities come and go, voluntary sector services come and go, they're not necessarily there all the time. And therefore it's been quite difficult sometimes to keep up with who's on the patch, who is doing what they need to do, where are the gaps and so on. But actually having, as I say, a platform whereby one of our VCSE partners came in and actually did the work for us to make sure that the Directory of Services is up to date. It's you know, it's made up of people who know what they're doing and are part of the community landscape has been really important. And so that's been a core building block really to build those relationships between the networks, the GP practices, people at what we call place, so that level of a network of networks, if you like, because some of these organisations are bigger than others. But then allowing those social prescribing link workers, those community link workers, to know exactly where the community assets are and then act as a really good quick conduit to help really quickly has been really important.
Sure. And of course, the VCSE has also played a key role in facilitating co-production with residents and understand need. And this is because of their embeddedness in the neighborhood. What has been your experience of working with the VCSE to understand need and to work with local residents?
I mean, I think going forward, again, we're at a pivotal stage of transformation in the way that our services work together. Not only will we be asking that there'll be no service redesign without patients, but also without our partners in its widest sense. And I think the VCSE has a really big part to play in that. I can describe our review of mental health services in Dorset that we undertook within the last couple of years, where we spent probably the best part of it a year view seeking rather than just creating what we thought might happen in terms of the design of our mental health services. And really interesting as a result of that, working with partners within the VCSE, working with our patients, working with people with lived experience, as well as our service providers. It gave us a very rounded view on the need of the population and also the places that people felt that they needed the access to services, which were not the conventional settings of care necessarily, and were often outside the normal hours of care even, and were in some very unusual settings, you know, for as opposed to the usual way that health services are being delivered, and hugely successful. And I feel that taking the time to listen and learn and understand and take the wisdom of our partners in its widest sense gives us the best opportunity really to land services properly where they should be, to the standard that we want them to be, and then constantly evaluating as we go to make sure that we have indeed got it right. But listening to partners is going to be critical, not just for mental health, but for all services going forward.
And thinking about what you said just now, what do you think that an asset-based approach would mean to residents? What difference does it make for them?
So So often, so there is something about immediate or semi-immediate to access to the services that people need. Of course, that's a very transactional requirement. There is also something which is much greater than just the sum of the individual services, which is actually building communities together to be empowered to look after their own and support each other in a way that I think we haven't seen in a very long time. So there's something about a culture change that an open mindset to working with new partners brings, that allows us to work much more closely with the local communities to understand what they need, and also for local communities to understand what their part to play is in terms of the prevention agenda, and making sure that they are as strong as possible. And you know, this idea about the NHS being an anchor institution at an integrated care system level, or even at, you know, the role of the NHS as an anchor institution for local asset development, workforce, jobs, security, all of those things which are the wider determinants of health that have such a high impact on the health of people, are critically important. And that kind of spirit of caring for each other, I think, is something that is very tangible and has definitely come as a result of the last year, and is a way of working that we must aspire to and lead going forward.
Sure. And, you know, as you mentioned, COVID has really been a catalyst for enhanced collaboration between the VCSE and formal health and care networks. So what's the future that you see for the population health management program? And what role do you see the VCSE playing post-COVID?
So, I mean, a couple of thoughts really. Much of what we have delivered through COVID could not have been delivered without the voluntary sector. There's no question. I mean, I'm thinking particularly about our impressive vaccination programme that has been delivered across Dorset and across the whole country. I know that we as clinicians and practice teams on the ground could not have delivered what we have delivered to the population without the enormous contribution of the VCSE in an organised way around local practice sites, around large vaccination sites, outside hospital sites. So I think we have a huge debt of gratitude to the VCSE for that, and we certainly wouldn't have been able to deliver what we have done without them, no question. But I would hope that that has built a different type of relationship within those local health systems and within integrated care systems, so that we can start to build on that progress and that maturity of relationships, and that coordinated function. So whether it's vaccination or delivering oximeters, pulse oximeters to people's homes, or whether it's befriending services to shielded patients, you know, all of that has shown us how important the VCSE sector is to our local communities and our local neighbourhoods. So it's really important that we remember and build on and nurture those relationships going forward. Second, it's really important that as we return to inclusive recovery, that we have a real focus on that, go back to the basics around a population health need and a population health managed approach. So using the relationships that we know that we have developed across the sector, we have the opportunity now to go back to that way of working and now build in a much more organised way how we work with local communities to better achieve those aims. Because as I said at the beginning, population health management does focus on health, but it also is not just about a medicalised need, it's also around the wider determinants, the non-medical, the social needs that come around, which holistically together enable people to be healthier in the longer term. So I think we have an opportunity now, as a result of where we've been in the last year, to build forward. And I think it's really important to recognise that we embed those VCS partner structures within our integrated care systems, within our system, in our places, and absolutely, as I said, where the magic happens at that neighbourhood level, so that they can play their part within service design. And also, we must, if we're going to truly aspire to that, we also need to understand what the sustainable funding to allow that to go forward, because clearly that needs to be part of the discussion going forward.
Absolutely. And Karen, just to finish off, really, what advice would you have for other areas who want to adopt a similar approach?
So I think key to this is relationships, having an open mindset, and being very open to new conversations with non-traditional partners. And that is at every level. So it's whether I work in a GP practice, I work in a primary care network, I work at a place in integrated care partnership, whether I work as an ICS level. It's having that vision for something different. It's having the ability to develop trusted relationships going forward, to develop those new partners, and to be really clear about the role that we all play together within our health and care systems to try and improve health. I think the second thing would be to really address the issues around making sure that the data really helps you to make those decisions. So it's really fundamental that you have a single source of the truth of the data, and that you understand what that is telling you as a local community, and then having the time and the headspace really to start thinking through some of those new care models as they start to emerge. And by that, I don't mean a single clinical pathway, I mean holistic care, integrated care in its entirety. And then just embedding really well-resourced, good project management around that to make sure that it is a success, and that we are building a sustainable programme for our integrated care systems as they mature over the next 5-10 years, because that's the amount of time it will take to become truly mature. But we need to give it time, and give these structures, and give this and make sure that we are embedding the right plans and procedures in place to be able to deliver that.
Great, thanks, Karen. Well, we came to the end of the interview. Thank you very much for sharing your insights on the population management program in Dorset, and for reflecting on what has been successful in your area, and most importantly, providing insights for systems that are willing to adopt similar approaches. So thank you very much.
You're welcome. Thank you.